welcome. I'm Dr. Richard Bogan, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's CMEO briefcase entitled Recognition of Narcolepsy in Your Patients. This program is supported by an independent medical education grant from Jazz Pharmaceuticals, and I am Associate Clinical Professor at the University of South Carolina Medical School in Columbia, South Carolina, and the Medical University of South Carolina in Charleston, South Carolina, and the principal of Bogan Sleep Consultants, LLC in Columbia, South Carolina. I am really delighted to be joined today by my distinguished colleague, Dr. Paul Dagramji. Please introduce yourself.
Hi, everyone. My name is Paul Dagramji, and I'm delighted to be here. I'm senior family physician at Collegeville Family Practice in Collegeville, Pennsylvania, and I'm also the medical director of health services at Ursinus College, also in Collegeville, Pennsylvania.
Well, Paul, we're looking forward to your insights. Our learning objective for today is to screen for narcolepsy based on patient presentation or patient or family giver, the family caregiver description of function and changes in quality of life, which can be particularly important in our pediatric population. So let's meet our patient, Raina. She's 15 years old, a Black female, and she presented to the primary care physician with her parents with complaints of being tired all the time and not being able to stay awake, starting when she was about age 8. Her parents report she struggled with school because she would sleep during class, but attributed this to being a light sleeper at night, waking up frequently. And they realized something was wrong when the patient was found asleep by the bus driver after dropping the bus off at the garage. She reported that she had struggled socially in school for some time and reported that she had depression symptoms as well as poor attentiveness. She wanted to be more involved in sports, but she didn't really have enough energy to participate. A PHQ-9 was administered. PHQ-9 was 13, and she was diagnosed with depression and prescribed escitalopram 10 milligrams on a daily basis. She was counseled on sleep hygiene and recommended therapy and advised to exercise 3 times per week. So this is not an unusual case presentation. Let's give our audience a chance to participate by introducing an audience response question. So which part of Raina's presentation is seen in all patients with narcolepsy? You have the answers there. Well, the answer is D. All patients with narcolepsy do have symptoms of excessive sleepiness. This, quite frankly, is part of our dilemma because many patients with sleepiness present as fatigue or executive function changes, can't think and focus, concentrate, or they may present with mood changes. So when we're talking about these symptoms, Paul, would you expand on how can we recognize narcolepsy patients? What are the symptoms?
Yeah, the most important thing for us to remember, folks, is that these patients are drowsy. That's a very important thing to note, in that these patients are drowsy. As you can see here on this slide, patients with narcolepsy, 100% of them complain of excessive daytime sleepiness. So these patients say things like they're tired or they're fatigued. They'll use words like that. And please keep that in mind. They may not use the word drowsy or sleepy. They may use other words. Tired is the most common word that they will use. And it can start at a very young age, and it can be confusing and somewhat misleading, because you'll think to yourself, well, maybe they're just depressed, as was thought to be the case in this case presentation, or maybe they're just not sleeping long enough or well enough. Well, that's the most important thing, is drowsiness. Now, drowsiness can be caused by not sleeping well. So it is important to get a good sleep history. We need to know how to be good sleep history takers. How long do you sleep? What times do you sleep? Does anything happen during your sleep? So if there's a circadian rhythm disorder, if there's a possibility of a sleep disorder like obstructive sleep apnea, we have to consider those things and ask questions accordingly. But on a young adult like this, who has a lot of drowsiness, we should also be thinking about the possibility of narcolepsy and know the other symptoms of narcolepsy, including cataplexy hypnagogic hallucinations, hypnopompic hallucinations, sleep paralysis, and also sleep disruption. We need to ask about how those symptoms could possibly be occurring in our patients. We need to know those.
Yeah, I think the message I also would say is that as a primary care practitioner, this is a rare disorder. You have a lot of sleepy people for a lot of different reasons, as you said, but you probably have at least one or two narcolepsy patients in your practice, maybe more. Obviously, depends. So it's up to you to find and ask those questions, and you're going to help us figure that out. So when these patients do present with these specific characteristics, sometimes they are the reasons they're coming in for a visit, but sometimes it's because of the impact of the sleepiness and the fatigue and the impact on functionality and quality of life. We have some data here, Paul.
Yeah, sleepiness that occurs once or twice now and then, here and there, is no big deal. But when it's going on as long as it does in these patients, day in and day out, that's going on for weeks and months on end, it can cause a significant impact on the quality of life. As we can see here, the quality of life in children with narcolepsy, as well as idiopathic hypersomnia, it affects them by giving them tremendously a large amount of sleepiness. It can affect their BMI. They have a tendency to be a little bit higher in weight. They can have a higher injury rate. They can have less physical activity. They're less inclined to be physically active, less extracurricular activities. Their grades may falter. Their physical functioning may be affected, as well as their social functioning. School functioning can be affected, and their overall quality of life is diminished. These parents, when they come in, they say, my child is just not doing well in many facets of life. So quality of life is definitely disturbed in these patients who have narcolepsy.
Yeah, I think you raise an important point in that the presentation is oftentimes atypical. It's not necessarily falling asleep in class or sleepiness, or it's, as you said, fatigue or mood changes or functional changes, because these kids don't know what normal is. They don't have a frame of reference. And sometimes, as you pointed out, the parents can pick it up better in terms of the impact on quality of life and functionality. Would you comment on that?
Yeah, again, in this next slide here, it says parents can be good reporters of their children's symptoms. Most parents are very concerned about their children and their children's well-being. And when they see that they are outliers, they're not doing the same as their peers, as others on the block, their classmates, they get concerned. They might do one or two or three things for their children. Maybe they'll change their diet. They'll ask them to get involved into more extracurricular activities. They'll come in and discuss with you and get a complete physical exam. But they'll tell you that, again, as it shows in this slide, their physical functioning, their emotional functioning, their social functioning, school functioning, and overall quality of life, they can be quite disturbed. And they bring this up to you. And you need to think about the possibility of a sleep disorder when patients like this come in and get a good sleep history.
Yeah, it's somewhat redundant, but on the next slide, the impact on the child and adolescents. We see it also not just in young children, but adolescents. Would you comment on that?
Yeah, I don't see as many children with narcolepsy. I see a lot more adolescents. You know, being a college physician, I often see students coming in with tiredness. So 17, 18, 19-year-olds will come into me with sleepiness and tiredness. And they will mention this to me, and they will discuss about how they're not able to do a lot of the things that their friends are doing. You know, they are not able to participate in sports as well as they used to. They have fewer friends, and they have less leisure activity. They're actually even doing worse in school as what they would like to. Their driving can even be hampered. So a lot of symptoms can occur in these patients who often come in wondering what's wrong with them. Why is it that they can't participate in life the way that their peers are behaving? So I see a lot of that in my adolescent patients, in the sense that I have to make sure that I rule out narcolepsy by asking the appropriate questions.
Yeah, I think you pointed out some very significant points in terms of when we see these functional abnormalities, you need to ask about sleepiness. And if they're sleepy, you can figure out why they're sleepy. They may have narcolepsy, and you can do something about it, which may have a huge impact on functionality. So let's revisit Raina 3 years later. So she returns to the clinic, obviously has been seen before, but now she is at age 18, and she says, "Doc, I'm still tired." Along with, other aspects of life events. She had had an automobile accident when she nodded off at the wheel. In fact, I warn my patients, don't put it on cruise control if you're sleepy and driving. She had noticed that she was having trouble let go from a part-time job because she often would not wake up for work. She'd be late for work. So she was interviewed for sleep symptoms and reported pertinent things that she was waking up frequently. She was experiencing hallucinations when dozing back to sleep. So she would wake up, and as she was going back to sleep, having weakness when laughing hard. And her Epworth score was done. It was 17 out of 24. And her PHQ-9 is now 7, assuming that she's still on the escitalopram. So let's give the audience another chance to participate in another audience response question. So you've heard her symptoms. Which domains of Raina's health-related quality of life appear to be most impacted by a possible narcolepsy diagnosis at this time? Well, the answer is C. She had significant physical role functioning and vitality abnormalities. So adults with narcolepsy also experience a worse quality of life, not just compared to the general population, but even with other disease states. So I think this gives us some quantitative data in terms of how we compare narcolepsy patients with the general population and other disorders. Paul?
Yeah, so the SF-36 can be really useful in trying to quantify the quality of life in our patients in many types of disorders that can happen. And in this specific slide, we're obviously looking at narcolepsy patients. This is a meta-analysis of 4,600 patients with a mean age of around 40, with a little bit more women than there are men. And it's showing the lower health-related quality of life in numerous domains compared to the general population with multiple chronic diseases, including multiple sclerosis and epilepsy. And if we look at the chart, we look at physical functioning, mental health, role, emotional, social functioning, vitality, general health, bodily pain, role, physical. Now, these are the different domains in SF-36, and we can see a substantial degradation in all these areas in patients with narcolepsy. So it affects their quality of life significantly, as we've already said, and I gave my examples. I'm an adolescent person, but also in the adult population, it can significantly affect their quality of life, and specifically as quantified in this SF-36.
Yeah, we use the SF-36 in a lot of our research to get validated measures of quality of life, the impact of disease, and quite frankly, the impact of medications. And while we know adults have worse quality of life compared to the general population in individuals with narcolepsy, can you be more specific about what the impact is in their functionality?
The impacts on the quality of life in adults can be seen in various forms here. And as it shows on this slide, patients are 2 to 4 times greater risk of, and take a look at this, health-related quality of life impairment, as we've already said. The prevalence of long-term disability. How about that? Increased absenteeism, not showing up for school or work. How many times have patients come to you saying, I'm too tired and I couldn't go to work, can you give me a note for work? Presenteeism. Presenteeism meaning that patients are there, but they're not firing on all cylinders. Their ability to perform, to have their tasks completed properly is just not there. Hospitalization, emergency department visits. Patients with narcolepsy can have more accidents and injuries, as we've said before. They can end up in the emergency room as a result of their accidents and injuries. Car accidents, for example. One of my college students came to me, and as she was talking to me about her tiredness, said to me that she had a couple of near accident experiences where her eyes were falling down like this and coming back up, and she had sideswiped another car just by doing that. And so car accidents, emergency room visits, increased traditional healthcare professional visits. These patients are feeling unwell, and they'll come to you feeling unwell. They can have also significant comorbidities. There's a higher rate of obstructive sleep apnea. There's a higher rate of obesity in these patients. And with them, the resultant other comorbidities can occur. So you are going to see a lot more of these patients in your office. And it's a very important thing then to look into the possibility about their sleep. I don't miss any opportunity for any of my patients coming in who are not feeling well to at least ask a couple of questions about their sleep. After all, we spend a third of our lives in sleep. It's a good thing to ask about at some point during their visits with you.
Right. Well, it's pretty clear that patients with narcolepsy experience significant changes in quality of life and symptoms and comorbidities. It's amazing you have this remarkable disorder with state instability, profound sleepiness, and fragmented sleep and vivid dreams, hallucinations, sleep paralysis. Not all of them, but you'd think it'd be easy to diagnose and remember that in your clinic you have some of these patients, so you need to identify them. Why do we have this? Can you comment this delay in diagnosis? I mean, what's going on here?
Yeah, I think we're going to the next slide here, which says the patient journey, the Nexus Narcolepsy Registry. It takes quite a while to diagnose patients with narcolepsy. And you can see on the upper left-hand side, for example, the mean time in years to diagnose a patient under 6 years of age. It can take 16 years to diagnose. 7 to 11 years of age, it can take 12.4 years, and 12 to 17 years of age, it can take close to 8 years to diagnose. Well, it's not very clear cut, first of all, their symptoms. It's not very easy to wrap your hands around their symptoms, first of all. And secondly, it can mimic so many other kinds of symptoms that come up. But third, it just doesn't occur that frequently. I think that's one of the things that can confound us. Narcolepsy doesn't occur that frequently, so it oftentimes escapes us on our radar, okay? And if you take a look at the adult symptom onset, excessive sleepiness, and as you said earlier, vivid dreams, but also trouble concentrating, poor school work performance. Sometimes patients even misdiagnose as having ADHD, but also obstructive sleep apnea. We should keep in mind that there's a higher rate of obstructive sleep apnea in patients with narcolepsy. So we can see the adult symptom onset on the bottom left-hand side there. The mean time for these symptom onset, it can be quite challenging then to diagnose patients with narcolepsy, and a lot easier for obstructive sleep apnea. And on the right-hand side there, the overall findings, the younger the age of onset equals a longer time to diagnose. I think that's an interesting point to make as well. The younger the onset of symptoms, the longer time it takes to diagnose. So when you have patients that are 8, 9, 10 years old, like we have in our case presentation here, it took her quite a many years until narcolepsy was eventually considered. The top symptoms leading to consultation: excessive sleepiness, trouble concentrating, poor work performance, vivid dreams. If you get that excessive sleepiness, though, that oftentimes is going to give you the best road into a sleep center where the sleep specialist will think about the possibility of narcolepsy and do the nighttime and daytime study. As far as the first consultation by frequency, the primary care providers at 55%, sleep specialists 19%, neurologists 12.5%. So first consultation by frequency, the great majority of the time, they're going to come to you as a primary care provider. I know I see a lot of patients coming to see me with tiredness, and I do try to put narcolepsy on my radar just to make sure that I don't miss that. And finally, as far as diagnosing by a clinician, this is something that's predominantly diagnosed by sleep clinicians, because you have to have a sleep study done, a nighttime and a daytime study done. You just have to, as a primary care provider, have it on your radar to make sure that you direct them to a sleep center who can then do the appropriate testing to rule in the condition.
Yeah, the delay in diagnosis certainly is very real. And again, because these sleepy individuals have quality of life changes, functional changes, executive function, mood, productivity, social interaction, all these issues that get treated for a lot of different things. I don't particularly like the term misdiagnosis, but they are treated for other things. Can you comment on that?
Well, as we can see in the next slide, yeah, I don't like the term misdiagnosis either, because sometimes it's actually comorbid. There are a lot of comorbidities associated with narcolepsy, sleep apnea, like I said, being one of them. But they can oftentimes be thought of as having depression. I know that in the college where I work, there are 5 psychologists who will sometimes refer patients to me with a diagnosis of depression because they're not attending class. They seem to be tired all the time, and they think maybe they have a depression. Maybe their PHQ-9 is a bit elevated, like it was in our case here. So maybe not a misdiagnosis, but a comorbidity. So keep in mind that when you have patients that have tiredness, that are maybe also seemingly depressed, or maybe they're not as attentive, maybe they're more anxious, maybe they're not sleeping as well, maybe you're thinking they have a mood disorder, maybe you're thinking they have sleep apnea, or even you're thinking they have epilepsy, and you want to refer them for testing. Schizophrenia, not so likely, but as well as dementia. But if you think about these possibilities, think also about whether their sleepiness could be coming from narcolepsy. I think that's where this slide is trying to direct us to, that when there are some common diagnoses that come to you in a tired patient, think about the possibility and start asking questions about cataplexy, about hypnagogic hallucinations, hypnopompic hallucinations, and about sleep paralysis.
Yeah, I think that Schedule II stimulants are commonly used for ADHD, and our narcolepsy patients are like, wow, this really helped. I must be ADHD. And of course, it doesn't address all of the symptoms, and it's not always completely effective. And the patients have trouble quantifying the response, but they'll be like, wow, I'm better. This must be what's going on. But you have to be suspicious for sure. So one of the most important things, and you pointed this out, that we can do when screening for narcolepsy is to conduct a proper and thorough clinical interview. And this can help us significantly reduce the amount of time it takes for patients to get a proper diagnosis. Can you give us some clues and hints there?
Yeah, we need to know, of course, about sleepiness. And the next slide, by the way, will tell us about the Epworth Sleepiness Scale, which we all should be familiar with. In my electronic medical records, I can pull up the Epworth, which we'll go over in a second, and quantify it right then and there. But we need to know about sleepiness and asking questions about what they mean by tiredness. Do you mean drowsy? Do you mean like if I were to have you lie down on this exam table here, go out of the room, turn the light off, and if I come back in 5-10 minutes, are you likely to be asleep? Oh my gosh, yes. 2 minutes, I'll be asleep.
Mm-hmm.
So the questions that you need to know to ask patients to extract that symptom of drowsiness, of sleepiness, that they may be specifically referring to when they're using the word tired. But we also need to then ask them about hypnagogic and hypnopompic hallucinations. When you're falling asleep, does it feel like you're in sort of like a dream-like hallucinatory state, whether you're falling asleep or coming out of it? Or if somebody tells you a really funny joke or scares you, do you feel as if maybe you get a weakness in your face for about 15-20 seconds, or your arm drops for 15-20 seconds, or your knees buckle? Does that happen? Well, this college student I was referring to, when I asked her about that, she said, well, doesn't everybody's knees buckle when they have a good joke that they hear? She thought it was normal, and it is not.
Sure. Yeah.
And then sleep paralysis. It has potentially happened to some of you out there, where when you're going off into sleep, you're not asleep yet, but you can't move. At sleep paralysis. It can happen normally in certain conditions, but these patients suffer from it in a much greater percentage of time. And finally, sleep disruption, where they're not really sleeping that well through the night. So knowing how to get a good sleep history when we're suspicious of narcolepsy is very important for us to know.
Yeah, I think the disrupted sleep is sometimes confusing because we think of narcolepsy patients as being able to sleep anytime they want. But they have state instability. So as you pointed out, they can be awake and dreaming at the same time. And of course, we're paralyzed when we're dreaming, so they may hallucinate or feel the paralysis. And they wake up a lot. When we wake up, we can remember things. And so oftentimes they are thought to have insomnia. That's why they're sleepy. But remember, most people with insomnia cannot take a nap. I mean, they're kind of stuck on wake, and they are tired, don't get me wrong, but they typically don't have an abnormal Epworth score. And you referred to that. I think the Epworth is very valuable. It allows us, are you sleepy? Qualify, and quantify, how sleepy are you? Discuss the Epworth in more detail.
Yeah, so they are 8 different situations that are relatively passive or inactive situations of life, like sitting and reading, watching TV, sitting inactive in a public place as a passenger in a car, lying down to rest, sitting and talking to someone, maybe a little bit more active, sitting quietly at lunch without alcohol, and in a car while stopped in traffic, all passive situations. Passivity in normal people makes them get edgy and bored and anxious. It doesn't make them drowsy. Drowsy people, when they're put in boring situations or inactive situations, they tend to nod. And that's what happens to these patients with narcolepsy. So we quantify this. We ask them to quantify their degree of drowsiness from 0 to 3, and we add up the score. And as you can see on the right side there, if it's 11 to 12, that's mild excessive daytime sleepiness. That's abnormal. 13 to 15 is moderate, and 16 to 24 is severe. So your narcoleptic patients are going to be in the 13 to 15 to, more commonly what I see is the 16 to 24 range.
Yeah, I would agree with that. And there is a CHAD, Epworth for children. It changes a couple of the questions, but essentially, as you point out, passive activity. And some of the patients with narcolepsy are like, I don't have that disorder, narcolepsy, because I don't just fall asleep. I can stay awake when I'm physically active. And I always tell people that when you're active, physically active, or you're having fun, you're not likely to doze off. So that's where these questions really do come into play. So, Paul, let's revisit the case and really kind of discuss some of her aspects that would point you towards having a diagnosis of narcolepsy in this particular patient.
Yeah, I think the teaching point here is that this young lady started off with tiredness, okay? And if the questions could have centered around her tiredness, whether that she was sleepy or not, and what her other symptoms could have were going on, it could have possibly pointed the clinician into the possibility of there being narcolepsy. So what should have been done on this patient in the first interview, maybe get a better sleep history. How can the Epworth Sleepiness Scale help us rule out other diagnoses? Well, it doesn't rule out other diagnoses in a sense. It just tells us that the patient isn't really fatigued or having, let's say, muscle fatigue like that can occur in thyroid disease or in anemia or that sort of stuff. It can zero in on the possibility that the patient's tiredness is more sleepiness. And what can help us differentiate comorbidities such as depression from narcolepsy? You can actually do a PHQ-9s like was done in this young lady. But specifically, you need to know the symptoms of narcolepsy and start asking them about it. And finally, when do you refer your patient? When you feel as if your patient has excessive daytime sleepiness and you can't account for it by something really simple, like a circadian rhythm disorder, like insufficient sleep syndrome, or like obstructive sleep apnea, and you've done some of the testing and some of the questioning, that's when you refer the patient to a sleep center.
Yeah, I think you raised a good point with the PHQ-9. When you think about sleepy people and you look at those specific questions about your energy level and your sleep and motivation and social interaction, I mean, sleepiness does a lot of those things. So I think it's, as you say, it's important for us to dig in and be suspicious at all times about this. So, yeah, this was an excellent program today. And thank you, Dr. Ramji, for your excellent discussion. And let's summarize our discussion with our SMART goals. In other words, our goals are to be specific, measurable, attainable, relevant, and timely. And that is what I hope you will take away from this presentation today to apply to your practice. I encourage you have these patients in your clinic, so screen all your patients with complaints of sleep dysfunction and excessive sleepiness for symptoms associated with narcolepsy. Recognize narcolepsy and its comorbidities associated with narcolepsy when considering patient presentation and patient caregiver description of quality of life during your office visits. Conduct effective clinical interviews that quantify the degree of excessive sleepiness, determine narcolepsy-specific sleep symptoms, and use patient-friendly language for every patient presenting with tiredness. So today's CMEO briefcase is part of a 3-part series of case-based activities that can be found on the Sleep Disorders Hub. I hope you will check them out. There are 2 other activities in the series. The Sleep Disorders Hub has these activities and actually many others that you can refer to. CME Outfitters has a sleep disorder hub with a number of excellent resources to share with your patients as well. So, thank you, Paul Dajramji, for joining me today, and thank you to our audience for joining us. Be safe and take care of yourselves so you can provide the best care for your